اوكي شوف obstetrics and gynecology in general. Do you all speak English and Arabic ولا في حدا ما بيتكلم عربي؟ Then I'll go English all the way. Now obstetrics and gynecology as a practice, okay? Every one of you is gonna require it and require the knowledge of it at one point of your life, whether you like it or not. Not like other specialties. Some other specialties you might not be involved in anything that you study with, except if you're in that specialty. But obstetrics and gynecology, you're going to need it for your family, for your wife, for your sister, or anyone who is in your family that you're going to encounter. That's why, if you're going to go out in medical school and go out with a few things that you're going to be definitely going to be using, is one of this is this lecture, okay? And knowing how to deliver a person. Because you don't want to be that person who's a doctor, proud to have a degree, and you're called in from a supermarket over the phone that someone is in labor and she needs to be delivered, and you're shy enough to say, I cannot be announcing myself as a physician because I don't know what to do. So that emergency situation is important. And the most common questions that will arise according to this, I'm not talking about your exams only, I'm talking about your career, is related to this. If you understand normal physiology of the menstrual cycle, understand what's normal, what's abnormal, and most of the questions in Ramadan and Hajj, how can I control my period? I don't want it to come. I want to make sure I don't ovulate. I want to make sure I don't get pregnant. Those are the very common questions. Okay? So it all comes back to this, if you understand what's happening here. Because the menstrual cycle is like a program. It's like you program a computer. According to that program and what you feed it, okay, you're going to have outputs. And that output can be the menstruation itself, pregnancy, okay, or amenorrhea. The lectures you took before I came about adenomyosis and endometriosis, how you control them, understanding menstrual cycle. Getting pregnant, infertility, understanding menstrual cycle. Menorrhagia, understanding menstrual cycle. So name the topic, comes back to understanding what's happening here. And that's why we have to invest in time to understand what we're going to be talking about. Okay, so because you're not a very big group, if you have a question, stop me directly. Okay, it's like let's make it like a workshop rather than a lecture. Now let's answer these. What's the mean duration of the menstrual cycle?
5 to 6 days.
5 to 6 days. Okay, so the menstrual cycle is different than the menstruation duration. The cycle itself, that is composed of different stages, is around 28 days. But this range can go up and down, okay, between 21 and 35 days. What does this mean? That at day 22, patient menstruates, and so on, and that cycle repeats. Okay, so that is irregularity. Though 21% or 15% of population will have a fixed 28-day menstrual cycle. Okay, what's the average duration of menses? That's the question you should be answering. Okay, تمام? Which is 3 to 8 days. في عندك أنت ماشي كويس أحسن. So the average duration is between 3 to 8 days. طيب, what's the normal amount of estimated blood loss that the patient loses during a menstrual cycle? Around 25 what? Around 30, yeah. You're close. So here, that's the normal. Okay. طبعا there is a big, very common saying: patients overestimate blood loss, physicians underestimate blood loss. So for you to estimate the actual blood loss, it has to have good history. So you have to compare to something. Is she passing blood clots? It becomes abnormal. If she's changing pads so frequently, it becomes abnormal. If she starts developing anemia or symptoms of anemia, this becomes abnormal. صح ولا لا? So normally, the normal cycle should be the first 2 days that she has a flow, and then slightly it starts to reduce its amount until it stops after 3 to 4 days. That's the normal range. But that can be variable from one person to another. Okay? So if it is heavy bleeding, what do you call it? Menorrhagia. So she's bleeding heavily, she's losing a lot of blood during a normal pan of 5 days. The normal duration. So the duration is normal, but it's heavy. That's called menorrhagia. Right. If it's 10 days, 12 days, 13 days, what do you call that? Metrorrhagia. Right? Okay. So now you can forget. Metrorrhagia. So it's okay. If it's both, metrorrhagia. Okay? Simple, صح? طيب. If it is without bleeding, her cycle goes on and she doesn't have any period coming out, what do you call that? صح? Okay? If it is less than 30 ml, very little amount of period that she has, oligomenorrhea. Very simple, صح? احنا معقدين الامور بس. صح? We like names, but we don't know. Okay? When does the ovulation occur? Usually موجود الجواب ها. Day 14 of from what? Where are you counting? Day 14 from the from when?
From the previous menstruation.
From the
Last menstruation.
first day of the last menstrual. In obstetrics and gynecology, we don't use لا هجري ولا Gregorian. Okay? Once we deal with our patients, we look at, okay, when is your first day of the last menstrual period? She says 1st of February. That's the beginning of your month. And from there, we start counting. So once we use induction of ovulation, we refer to that date. So we start our induction of ovulation medication from 3 to 7 days. From ايش مين أول يوم? First day of the last menstrual cycle. If we're gonna see when she's gonna ovulate, we count 14 days from the first day of the last menstrual cycle. We want to do the lab tests to see if she is ovulating, having follicles. Again, we measure it from the day of the last menstrual cycle. And we're going to see that in this lecture. That's why this lecture combines infertility, combines adenomyosis, combines endometriosis, combines induction of ovulation. You get my point? Right. What regulates the phase of the menstrual cycle and ovulation? Hormones, which is a balance between what systems? What are the systems involved in regulating the menstrual cycle? Ovaries, hypothalamus, pituitary. So that, okay, those in combination, the regulation ونضوج العلاقة. Now, at the beginning, once a girl is born, there is some kind of activity, okay, and she's at 12 years of age, she starts menstruation. There is kind of activity of those, but they're not mature. And that relationship between those is not really sound. But at a certain level, when she's mature, then that regulation, البرمجة, becomes a regular system of hormones. You get my point? For that maturation is what you're looking at between those hormones. What's the mean age of menarche and menopause? What's menarche?
First,
So what's the mean age?
14.
Okay, and what about menopause?
45, 50.
55 to 60.
Okay, so menarche usually at 12 years, 12 to 7, 13 years. Okay, menopause is 51, but that is variable. So that's why once we say amenorrhea, she's primary amenorrhea, that she never had any menstrual cycle. Here we're talking about a range of age. So it's acceptable for a 14 years old to still did not have her cycle. But is it acceptable for someone who's 17 to not have yet her cycle? So there is a limit. So at 16, if she reaches 16 and above, there is a problem you have to address. Okay? And if she develops menopause at an age of 40, is this normal? 40, is it normal?
Yeah.
30, 41?
I think early still.
Anything from 40 and above is considered acceptable. Okay? Anything less than 40, here we have يسموها premature ovarian insufficiency. Okay? من زمان كانوا يسموها premature ovarian failure, but now they name it premature ovarian insufficiency. This means that she went into menopause earlier than is expected, which happens in 1% of the population. Okay? So that's the normal. Interesting?
Okay.
Now, so the menstrual cycle, okay, is composed of these stages. There's an area called follicular phase. There's an area of ovulation. And there is an area or time of luteal phase. Okay? And you can see that fluctuation of hormones. هنمشي عليهم, and we're going to try to understand all of them. But what does these affect? They have an effect على اليوترس والovaries. Because there is a very important effect على endometrial lining. Why is this important effect on the endometrial lining?
Prepare.
For the pregnancy.
The implantation. It's preparing the uterus for an implantation. So it's important to affect the uterus. It's also important to affect the ovary. Why is it important to affect the ovary? To ovulate. If you don't have these two, pregnancy will not happen. Okay? So we're gonna go through this. You can see there's a combination of hormones. It's like a scary picture, صح ولا لا?
Kind of.
صح?
Yeah.
Very scary picture, but it's very simple actually. If we look at it one step at a time. So we're gonna take the follicular phase. تمام? Starting with the follicular phase, then we're gonna go to the ovulatory phase, then we're gonna go to the luteal phase. Now, we said that there's a hypothalamus, okay, and pituitary, and then gonads, صح? Either testis or ovary. You're gonna find that with elevation of one hormone, there is a positive effect on the other. But sometimes a certain level of that elevation here causes a negative effect on the first. But let's see this. In males, okay, hypothalamus produces the hormones. It goes to the testis, okay? So the elevation here does not have a negative impact here. Sorry. Okay, how do I go up? Okay, so GnRH goes as pituitary, secretes FSH-LH, so it goes positive to the testis. Right? Elevation here, it tells the hypothalamus, it's okay, I'm fine, I'm working fine. Don't increase your secretion. On the other hand, if you look at the female, there is an area where you have at a certain age, a certain stage, you have GnRH, positive effect on the pituitary, it secretes FSH-LH, then it goes to the ovaries, and once a certain level of estrogen is there, it has a negative effect. And sometimes it has a positive effect. If you understand this, this is where the secret of the menstrual cycle. Okay? So now we're going to look at this area because you're going to see this frequent times. Here we're going to talk about the follicular phase, and we're going to start talking about the hormone and the effect on the endometrium, the effect on the ovary, okay, and then how the cycle of hormones occur. Okay? So you can see that part of, we're going to find here is temperature. ليه؟ لأنه some hormones have a thermogenic effect on the body, and this affects the temperature of the patient, okay, where it elevates it at a certain point. So this is where the follicular phase is. Is this clear? تمام? So what happens is, at the beginning, and see here the effect on the endometrium and the follicles itself. So this is how the menstrual cycle is going. Now, first day of the menstruation, when she starts menstruating, the female, we start with something called follicular stimulating hormone. Starts to rise. Like, why is it rising? It's rising to say to the body, we have to start recruiting follicles. Because we did not get pregnant the last month, we have to start and try again. So we have to start recruiting follicles. And this is by the elevation of FSH. So FSH, now the woman is born from the childbirth with a number of follicles in her ovary. And they start getting depleted with time. They are not newly mature. Yani with age, they don't form new follicles and they start growing. No, it's a number that gets depleted with time. And that's why some patients get depleted and have premature ovarian insufficiency if they deplete their follicular reserve early, okay? And some have a late menopause where they still have and they still get pregnant at advanced maternal ages, okay? So this number of the follicles that they have in their body. So here FSH, when it is rising, it recruits some follicles and it starts maturing them to see which one of them is going to be the dominant follicle of that cycle. Most of the cycles have one dominant follicle, but sometimes some cycles have more than one dominant follicle, and that's where we have twins. Okay? Now, once it reaches maturity, okay, a selection occurs. But why does this selection occur? Why is this follicle being selected? It depends on the amount of estrogen it has, and it depends on the amount of fluid that it has. The higher the estrogen, the higher the fluid, that's the best follicle we have for this month. This is what we're going to use. Okay? And that's what the body does. So the higher that the follicle has in estrogen and fluid, and this is why the selection occurs. So then what happens to the rest? The rest will get atretic. They will die. They will regress. So that dominant follicle will continue to grow. And it continues to have estrogen. It's growing, okay? Until it reaches a certain threshold. Once it reaches a certain threshold of estrogen, this is what it triggers something called the LH, luteinizing hormone. Like, why does it do that? Why do you think LH is there? This is what bursts that ovary. It reaches the maturity. Okay, now we're ready to launch. That LH level reached, which means that this is a very mature follicle, and this is where we go to the ovulatory phase. Okay? So you can see here the growth, the FSH is rising, and then LH is also rising because estrogen is also rising. At a certain level, then you have the beginning of ovulation. We're going to talk about ovulation in a minute. But what happens in follicular development, it goes through stages: primordial follicle, primary follicle, and so on, with the number of cells inside of it to grow, because now this follicle is preparing itself to do what? That follicle is preparing to be fertilized. Where does fertilization occur?
In the fallopian tube or after?
In the fallopian tube. And then, after being fertilized, it goes and also implants itself into the ready hospitable area, which is a thickened endometrial lining to be implanted. صح ولا لا? Okay? So now we go to the ovulation. And we mentioned that at a certain level of estradiol, then you start having that LH response. Before that pituitary maturity, pituitary axis maturation, which is at the age of 12, 11, that relationship, estrogen goes out and then the response of LH does not occur because they still are not familiar with each other. They're still not friends. They don't know what to do once this goes up and this goes down. But once patient matures at a certain level of estradiol reached, and this is where the LH surge occurs, okay? Where ovulation occurs, okay? So that positive feedback backs to the, goes back to the pituitary and gives that LH surge, okay? What happens if the LH surge goes up? And we start secreting progesterone, which is the hallmark of the second part of the menstrual cycle, okay? So you can see here, this is what happens. At that point, as the progesterone rises, temperature rises. And that's why part of how I know a patient is ovulating is through multiple ways. How would I know that a person is ovulating? Not feverish, temperature rising. There's a certain point where her baseline temperature rises. That's one. What else? How would I know?
Mood changes. Mood changes, blood pressure.
Blood pressure? No. Let's think. Think simply. مو كان في follicle. So by ultrasound I can see a follicle. صح ولا لا؟ مظبوط؟ طيب. What else? مش estrogen level. Progesterone level. I measure progesterone. If she has low progesterone, this means that she has no ovulation. زي عند مين بيحصل؟ Postmenopause.
أو
Young who do not ovulate. زي مين؟ Polycystic ovary. صح؟ Polycystic ovarian syndrome. مظبوط؟ Any disease that have unopposed estrogen. يعني estrogen عندهم بس ما عندهم progesterone. ناس عندهم infertility, patients with polycystic ovary syndrome, okay? Those, they don't ovulate, they don't get pregnant, and that's why they have to go to assist reproductive technology to help them get pregnant, because we want to make sure they ovulate. And one way of regulating a cycle, if a patient has irregular menstrual cycle, is either control her by control certain pills or helping her to ovulate.
Give her progesterone.
Help her to ovulate, induce ovulation. Or supply her with progesterone. See? Make sense? So if you want to make sure a patient has a regular cycle, make sure you control that progesterone part of her menstrual cycle. No one has a problem in estrogen. No woman has a problem in estrogen. Very rarely that a woman has a problem in estrogen. Why is that? يلا له 10 ريال اللي قاعد 50 ريال
Because they don't have
60 ريال
because they don't have male gonads, so they can't
No.
convert it.
Estrogen comes from
70
bones,
ريال.
comes from multiple.
ما حدا ياخذ
Estrogen comes from bones, multiple organs.
لا, where does estrogen come from?
The
fat tissue.
Hmm?
Fat tissue.
Excellent. ما حتاخذ فلوس Skin, subcutaneous tissue fat changes into something called estrone, which is a weak estrogen. So estrogen, besides being secreted from the ovary, you have a supply of estrogen from. That's why there is very rarely a female who has a problem in estrogen, but they have commonly a problem in progesterone. So if you control the progesterone side, you get to control the menstrual cycle. إلى الآن واضحة الأمور؟ Clear? Any question?
I have a question.
Yes.
Is this more like athletes who are very than anorexic? They may get amenorrhea. Is it because of estrogen?
عيدي سؤالك. Repeat your question.
The athletes,
Yes, what happens?
like they get amenorrhea
Why?
because of low fat or low.
Thank you very much. You're right. So severe athletics we measure their body fat. If their body fat is very low, they are depleted of estrogen. What happens to those people besides amenorrhea? كمل شكلك تعال. Someone you deprive of estrogen, what happens to them? What? Dryness, yes. صح.
Predisposition to cancer.
Hot flush.
Hot flushes, yes.
Osteoporosis.
Osteoporosis.
Osteoporosis and fractures, yes.
No protective effect on the heart.
Yes. You get my point? And that's why patients with premature ovarian insufficiency, هذول خطر لأن they're very young and they are now depleted of estrogen and progesterone. You got it? خدنا كل المنهج اليوم. صح ولا لا؟ مظبوط؟ You see, everything is linked. طيب. Okay? نكمل. فبيجي الovulation. So why does ovulation occur? Let's search. What happens? The pressure inside the follicle expands, and that pressure, with the presence of enzymatics that rupture the follicle, bursts, and this is where that small follicle escapes and now is ready to be caught by the sperm to be fertilized. حلو الكلام؟ تمام؟ And then we go to the luteal phase. So in the luteal phase, we have either a fertilized ovum or we don't have a fertilized ovum. في كل الأحوال, we have a certain of events that happen. We have higher progesterone, صح ولا لا? To see if she gets pregnant, she's ready. Something supports the pregnancy, the endometrial. If not, then menstruation occurs. Okay? So progesterone is the hallmark. Why is progesterone the hallmark of this part?
So that thickens the endometrium.
Thickening of the endometrium per se is not what it does. Estrogen is thickening. Estrogen is thickening. But what is it doing in particular?
Makes it more vascular.
It's helping in the vasculature of that area. So now I have something building up, and I have now something making sure that the endometrial thickness has enough supply of blood by spiraling vessels in that endometrial lining. Okay? To make sure it grasps, if pregnancy occurs, that it becomes a good hospitable area for a pregnancy. تمام? And as we mentioned, the thermogenic effect in the body. تمام? Now, no pregnancy occurs, no fertilization occurs. What happens? قبل هذا, a very short drop of what? Progesterone occurs. And the sharp drop of progesterone that occurs, okay, what happens to the vasculature?
It will be diminished.
Okay, that starts the cycle again. You see, directly estrogen and progesterone goes down, and then a new cycle starts, and this is a new cycle that begins. Okay, if a pregnancy occurs, what happens? The progesterone will stay stable. It will stay at a certain level, and because of the fertilized ovum that implants, you start having human chorionic gonadotropin (HCG), which also supports the pregnancy. تمام؟ طيب. Why? How would I know from a menstruation cycle, if I take a biopsy, what day of the menstruation I can? By looking at this. Now this is the endometrial lining, okay? This is the endometrium, this is the muscular layer, and this is the basal layer. This is the endometrium from here to here. So in that area, we have tissue and we have glands. Those glands has blood vessels running inside of them. Okay, you can see that? So the effect of the cycle goes on specifically the outer layer, the stratum functionalis. This is what sheds out during the menstrual cycle. This does not shed. From this image, I would know with the spiraling of vessels that you can see that she's at day 21 of the menstrual cycle. You get my point? This is a very ready endometrium for implantation. If I don't have, or I have very crowded glands, and I have little amount of little amount of tissue in between, with more glands. This is the histopathology that they see. You're going to see that later on in other lectures. With crowded glands, this is what we call endometrial hyperplasia, and developing into endometrial cancer. Okay? Okay, see physiology. Tamam? If I am at day 21 and I don't have those spiral vessels, or the spiral vessels end here, this means that there is a mismatch between the estrogen level that grows the endometrial lining and the progesterone. So what is she lacking? Progesterone. You see how? Makes sense, صح? مظبوط؟ So هذه فهمناها بالشرح. Okay. تمام. And then we have a new follicular phase that begins. Okay, and you start having the recruitment, the higher FSH, and so on. So she starts shedding those. Tamam? How does the shedding happens? Yeah, here, that's it. Okay. You have that drop of progesterone increases the secretion of something called prostaglandins. Prostaglandins cause vascular constriction, and that vascular constriction causes the shedding of the endometrial lining. طيب, what's the problem of adenomyosis that you talked before? And what is adenomyosis? What is endometriosis?
Adenomyosis is when the endometrium expands to the lining.
يعني داخلة هنا.
Yeah.
يعني الجلانز هنا. That's adenomyosis. صح? So معناها what happens to the endometrial lining in regards to the response of the changes in hormones will happen as well here. So she's going to have endometrial lining growth here and shedding here. And this is where she comes with pain. صح? A bulky uterus, tender uterus, painful uterus. صح? But what is endometriosis?
Endometrial tissue
Elsewhere, outside the endometrial lining, outside the uterus. Can be in the peritoneal cavity, can be on the wherever it is, a pouch of darkness, صح? Which means that what happens here is happening there. صح? تمام. So due to what? ما بقول السبب الانdometriosis or adenomyosis, but why is it responding to this?
Continuous progesterone.
Continuous progesterone. هلا البروجسترون continuous لا ما هو الجواب الصح.
They have estrogen receptors.
Because there is a drop in progesterone هذا الجواب الصح. لاحظوا انتوا البيشنت اللي she never had a drop in progesterone, what happened to her? Her body thinks that she's pregnant, صح? So her progesterone maintains it all the way. صح? She doesn't have prostaglandins at that time. No vasoconstriction, no shedding. مظبوط؟ طيب نفكر فيها. So how would I prevent pain for patients with adenomyosis?
So we supply them with progesterone and give them cortisone.
Yeah, give them progesterone.
Give them progesterone. صح؟ لا تخلي عندهم withdrawal progesterone. معناها their progesterone is continuous. If you have cyclical progesterone withdrawal, this will cause them to shed at the areas where you don't want them to shed. صح? So if you supply them with continuous progesterone, their endometrial thickness will stay as is. It will not change. So you give them long-term progesterone. You put them in a pseudo-pregnancy state. But you convince the body that she's pregnant, or get her pregnant. You got it? Now, what is a high progesterone state? Pregnancy. Or supply her with progesterone. So you convince the body that you give the supply of progesterone, which mimics a pregnancy state. So it's a pseudo-pregnancy state.
But why is endometriosis like happening because of low progesterone? I don't get that correlation.
لا مش endometriosis happens because of progesterone. Her symptoms will increase بسبب fluctuation progesterone. Every time she has progesterone, she has a thickness of endometrium, she has vasculature in that part. With the sharp drop of progesterone, that area sheds, she starts to become in pain. Her symptoms gets worse and worse because that shed of endometrium goes somewhere else and it plants itself somewhere else. So it becomes progressive. And from first stage, she goes to second stage, she goes to third stage endometriosis, she goes to fourth stage endometriosis. You got my point? So shedding of endometrium, which happens anywhere, whether inside the uterus or outside the uterus or in the endometrium, will happen because of the sudden drop in the progesterone. Is this clear?
So in patients of endometriosis, the sharp decrease is sharper than normal people?
Not sharper, but she has a lot of areas where this affects her. It affects her inside the endometrium, and it also affects her at the areas where the implantation of endometriotic seeds happen, which can be bowel, which can be omentum, which can be ovary, which can be bladder. Got it? Clear? Any question? So you see that image المخيفة كيف مشينا فيها؟
تمام.
Makes sense؟
نعم.
مشينا على الفوليكولار فيز، مشينا على ovulatory phase، ومشينا على luteal phase. And you see that combined. طيب بدون ما نطلع هنا. From the story, what is this hormone?
Progesterone.
What is this hormone?
Estrogen.
هذا استروجين وهذا
FSH. Amazing.
في أحلى من هيك؟
ولا في أحد.
صح؟ مظبوط؟
مظبوط.
That's it. أخذت endometriosis, adenomyosis, infertility. طيب induction of ovulation شو تتوقعوا فكرته؟
We're stimulating LH so that progesterone.
مش LH.
Give them high dose estrogen.
You want to recruit follicles صح؟ Which hormone recruits follicle؟ FSH. طيب فين أعطيه؟ إذا أنا بدي recruit follicles فين أعطيه؟ أعطيه هنا ولا هنا؟ هنا. That's why induction of ovulation starts from حتلاقي أي infertility physician. أول سؤال بسألها بقولها أول يوم في الدورة تجي لي علشان بدي أعطيك الدورة. ليه؟ لأنه that's the area of recruitment. So they start giving the induction of ovulation medication to start recruiting. Then هتلاقي infertility they ovulate, they observe the patient for ovulation by observing the follicle by folliculometry by ultrasound to see that follicle. Once it grows, that follicle grows to up to 18 millimeter by the ultrasound. It's ready to what? To be birthed. شو بيعطوها؟ بس ما بيعطوها LH، بيعطوها human chorionic gonadotrophy. يسموها الإبرة التفجيرية. Okay?
Works as an
Yes. So that big amount of HCG injection, okay, mimics the LH surge. Then, إذا كانت IVF, would they want her to ovulate? What is IVF؟ إيش الفرق بين induction of ovulation لامرأة بدون IVF واحدة بتسوي لها in vitro fertilization? What's in vitro fertilization?
Then we take the ovum from her, we implant, and we do all the procedures outside, then we bring it back.
باختصار, okay, a regular patient you ovulate, يعني you want her to ovulate automatically, you give her induction ovulation, and you wait for her to ovulate on herself, by herself, and you tell her that there is time that you have to have sexual intercourse where there is high fertility time, which is the area of ovulation, between day 13 to day 14, okay? IVF is that you give her induction of ovulation medication, you want to stimulate her ovulation, you don't want her to ovulate. You want to aspirate those follicles and then take the sperms, put them in the petri dish. حيكون في جزئين. جزء you're just gonna mix the sperms with the follicles and you wait for them to fertilize themselves, or بتسوي حاجة اسمها ICSI اللي هو intracytoplasmic sperm injection. You take a follicle and you take a sperm and then you inject that sperm into that follicle. So that's ICSI. So they want to prevent that LS surge. Because if IVF physicians have an LS surge, they lost the cycle. So they want to catch her here. You got it? واضحة? You see, it's all physiology. Right? So if I have a disease, if I have a patient that بدها تروح على العمرة وما بدها البيريد تيجي, what do I supply her with? Progesterone. If I have a patient who has irregular menstrual cycles and I want to regulate her menstrual cycle, what's the least medication I can use with her? Progesterone. بس كيف? That I supply her with progesterone for a period of time and then I told her to stop it suddenly because she's going to have something called withdrawal bleeding. So روحي خدي بروجسترون لحد ما تخلصي العمرة. بعد ما تخلصي وتحسي حالك انت you're okay to menstruate, stop the progesterone, you're going to have a period. You got it? Yes.
That's what you mean by this.
لأنك أنت ممكن تستخدم one hormone, ممكن تستخدم two hormones, وممكن تطفي السايكل كله by giving her FSH. If I give her FSH, I block everything because I have, if you look at the first slide, a negative feedback. I shut down the whole cycle. Okay? And that's why one of the treatments of adenomyosis and endometriosis is shutting down the cycle. Putting her into a menopause state. If she's menopause, she's not going to ovulate, she's not going to have FSH, she's not going to have LH, she's not going to have progesterone, she's not going to have shedding. I also control it. But that has the side effects of menopause. Okay? Clear? Any questions?
يعطيك العافية.